Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today, our speaker is Dr. Stacey Barrie. She was born and raised in the Bay Area, where she attended Marin Catholic High School. She received a biology degree at the University of California, San Diego, and completed medical school at St. Louis University. Dr. Barrie returned to California to complete her residency at the University of California, Davis, and she is board certified in obstetrics and gynecology and has been practicing in Fremont for the last 10 years.
So I'm actually just finishing my 12th year in practice here, and I wanted to share with you how things have so dramatically changed in the field of gynecology now that we can treat the common GYN benign conditions in very minimally invasive ways. And so in 12 years, things have changed so dramatically. I thought it'd be a good idea to share with the women of this community that there's no reason to suffer anymore. We have lots of options, and things are just not nearly as involved as they used to be to surgically repair and correct these things. So I was just going to go over 3 common conditions and how we treat them in a minimally invasive way. So some things that I treat as a GYN surgeon would be like precancerous changes, pelvic masses, women who have abnormal uterine bleeding, excessive menstruation, flooding, clotting, prolonged menstruation, people who have chronic pelvic pain by a chronic pain condition called endometriosis, fibroids. Fibroids are the bread and butter of my career. They're what pay the bills because they're so common. Those are benign muscle growths that happen in the uterus and can cause a variety of sensations such as pelvic fullness, bleeding, pressure, extremely common condition, and then urinary incontinence, stress incontinence, which affects a large percentage of women, which is the involuntary leakage of urine when we don't want to be losing urine. So I'll go over all these conditions, and I thought it'd be good to go over them in like little patient vignettes so you can understand how I spend my day and how I treat these conditions. So when we're talking about minimally invasive procedures, we're not talking about open surgery. Open surgery is a classic approach, and we typically have done that in large midline incisions. Not long ago, we were doing cesarean sections in that type of incision, or people who had large uterine masses had to have that big incision that would go from the belly button all the way to the pubic bone. Or most of our surgeries in the past have been done through this incision low, what we call the bikini cut, or the fan and still skin incision. A lot of you ladies might have those from having a cesarean section or having your uterus removed or having your bladder lifted. Even 5 years ago, that's how we were doing these surgeries with large 10 to 15 centimeter incisions in the lower abdomen. When we talk about minimally invasive surgery, we talk about lots of different approaches where the incisions would be. It can mean a vaginal hysterectomy is minimally invasive because there's a quick recovery times and there's no abdominal incisions. Conventional laparoscopy, gynecologists were really the first people to use the laparoscope in surgery, and we would typically use it to diagnose problems in the pelvis or perform sterilization procedures. Some of you may have had a laparoscopic sterilization with little tiny incisions in the belly button and maybe one above the pubic bone. This is a surgery that I do at the hospital. It's called robotic assisted surgery. It's laparoscopic surgery, but I use a robot to assist me to give me improved dexterity. And then hysteroscopic surgery is when we do surgery through the natural opening of the cervix. So there's no incisions at all in the abdomen or the vagina, but we use the cervix as the entry to enter the uterus to remove tumors from the uterus, as well as perform sterilizations. So those are all minimally invasive. And why is that important? Why do we want to do minimally invasive surgery? Well, minimally invasive surgery benefits the patient. A woman's going to have reduced blood loss, fewer complications, mainly due to smaller incisions, as well as less blood loss. The most impressive advantage of minimally invasive surgery is the shorter length of stay. So typically, just let's say 5 years ago, if somebody had an incontinence procedure, they'd spend 2 nights in the hospital, have an open incision, be off work for 6 to 8 weeks. Now we make a 1 centimeter incision in the vagina, 1 to 2 centimeter, less than an inch. They leave directly from the surgery center, and they're back to their normal activities within 2 weeks. So we're talking about much faster recovery, less scarring, and with a smaller incision comes less pain. These modern hysterectomies are ways I remove the uterus. I call them the cocktail party hysterectomy, because if I do them on a Wednesday, that patient not only could drive herself to a cocktail party, but to attend the cocktail party. So we're talking downtime of 2 to 3 days versus several weeks. So it's just much better for the patient. And improve cosmesis. Who wants to have a big midline incision? Not going to be able to wear the bikini. People would much rather have little tiny 1 centimeter incisions on their abdomen than a 10 to 15 centimeter incision. They just feel more comfortable about the way their body looks. So this is classic laparoscopic surgery. A lot of you probably have had it before or know people who've had it. And not only gynecologists do these surgery, but general surgeons do laparoscopic surgery as well. It means using a laparoscope, which is a camera on a stick. I call it a camera on a stick. See that camera? It's on a long tube, and it's attached to a light source. And I can see the organs. This person's doing a gallbladder. I don't do gallbladder surgery, but this person is looking underneath the liver and removing the gallbladder laparoscopically. So make a series of small incisions. We have amazing visualization through these cameras. These cameras can see so much better than our eyes can open. We can get up close and personal. Every little tiny 1 millimeter blood vessel looks like it's magnified 10 to 15 times. So the clarity and that improves the safety and reduces the blood loss. Because if we can see it, we can stop the bleeding much faster. So let's go over some vignettes of some procedures that I perform. These are examples of patients that I see every day and how I would treat them. So let's use Miss Smith as an example. Assume she's a 43-year-old woman who's had 2 babies and she's not planning on having any more. And she's coming to me because she's complaining of just heavy vaginal bleeding. She's bleeding excessively and prolonged. And when she starts to bleed, it's hard to contain in the sanitary products. Pads and tampons are no longer, can absorb all the menstrual loss. And this results in her soiling her clothes. Sometimes her office furniture, she'll bleed onto the chair at the office, sometimes onto the couch and on the bed sheets. So this makes her not want to go out in public, and it makes her kind of limit her activities, her normal daily activities. She's fearful of this time of month, and it's interfering with her daily living. At the same time, besides just the bleeding, she also just feels really full and swollen in her lower abdomen. She has pressure constantly on the bladder. It makes her need to urinate like every 1 to 2 hours. It's difficult to have intercourse because it causes a bloating sensation following intercourse. And she's tired. She's really tired, drawn, worn out. And she feels like she's bleeding excessively. When we ask a patient how much they're bleeding, we want to know how many days they bleed from beginning to end. And it's normal to bleed up to 7 days. Now, most people bleed heavily 1 to 2 of those days. But if you're bleeding more than 7 days, or if you're using multiple sanitary products either together or throughout the day, and what's excessive would be more than 6. I mean, this is all kind of subjective because some people will change with the first little drop of blood on it, and some people will wait until it's soaking through. So these number counts are kind of subjective, and that helps us. We need to use other things, sometimes laboratory values, to help us determine if this is excessive or not. So when I take a look at her, Miss Smith appears very pale and tired. Inside the vagina, everything looks healthy, but she is bleeding quite a bit. And when I look into the cervix, I see the flow. I can determine if it's normal or excessive. Most patients are embarrassed to come to the gynecologist when they're menstruating, but if you're having a menstrual problem, that's the best time to come because we can judge whether or not it's excessive. And it's certainly not embarrassing for us. It's actually very helpful for us. It's what we do. So people should be reassured that coming to the doctor on your menstruation, if you're coming for menstrual problems, is very important. any abnormal bleeding. If you're there for just a checkup, a well woman exam, it's not the best time, but if you're there for a problem, it's the great time. So when I do her exam, so we call the bimanual exam, where your doctor puts 2 gloved fingers inside the vagina and then presses on your tummy. That bimanual exam reveals a very enlarged uterus, which is irregular in contour. And a normal uterus should be about 7 to 8 centimeters, and we call that gestational age. So a resting non-pregnant uterus is 7 to 8 centimeters, so we call that 7 to 8 weeks. As a woman gets pregnant and the uterus starts to enlarge, we know how big the uterus should be for that gestational age. So her uterus is 15-week size, and that's equivalent to being 15 weeks pregnant. So normal 7 to 8, hers is 15, and it's also irregular. I can feel little knobs and twists on the top. It's not smooth and not bell-shaped on top. So that's a concern. When we do her blood work, we find that she's significantly anemic. So a normal blood count, it shouldn't be lower than about 11.5 hemoglobin, but this patient, her hemoglobin's 8. And that means she's lost about 1/3 of the blood volume in her body, and that makes her suffer. She's tired, she doesn't have the tolerance of exercise. It interferes with her ability to enjoy her living. So my diagnosis in this patient is that she has fibroids that have resulted in significant amount of symptoms. She has symptomatic fibroids and resulting anemia. Her hemoglobin's 8. 8 is not life-threatening, but we don't want to perform elective surgery with a hemoglobin of 8. So I need to do a little work to get her healthy enough to withstand surgery. And so I usually use an anti-hormone injection called Lupron, which will turn off the blood flow. It'll put her in a temporary medical menopause. It'll stop the bleeding, and then I'm going to replace her iron by giving her a prescription strength iron supplement. And usually within 3 to 4 weeks, I can get that hemoglobin from 8 to above 10. And if it's above 10, I feel safe taking a patient for elective surgery. Certainly not normal, but it'll get us to where we need to get through a safe surgery. So once her anemia is resolved, I'll perform what's called a robotically assisted laparoscopic supracervical hysterectomy. So what does that mean? So first of all, what's a robot? This is what the robot is. It's a console, and this is where the patient's bed is, and this is the robotic arm. These are the brains that communicate the two. So these are like those instruments that you just saw, the laparoscopic surgery, that where the person was performing the gallbladder surgery. But instead of being held by the surgeon, they're held by robotic arms, which are controlled by the surgeon. And the surgeon is not at the patient's bedside like we traditionally are. We're actually separated by about 10 to 15 feet. So I insert the instruments inside the abdomen, attach them to the robot, and then I actually get out of my scrubs, my gown here, I'm still in my scrubs, and I walk over and sit at this console, and I perform my surgery sitting down in this robotic chair. All of my hand motions are controlled just as I would move them in space. My hands are attached to instruments, and I just freely, as if I was sewing in the abdomen, I move them in space. However I move my hands, it moves these instruments. So I can perform the surgery as I would in an open situation, like cutting the woman open, like we traditionally did, but without making those big incisions. Why is this good? Well, these surgeries are so much better for dexterity. So traditional laparoscopy, I have a two-dimensional approach. I can go this way or I can go this way. And with robotic surgery, I can move my hand just as I would move my hand in nature. So I can get around small corners, I can dissect small surfaces, and so I can move my hands much better. So it's better for complicated surgeries. Traditionally, for laparoscopic surgery, it's hard to sew because I can't twist my arm like this. And companies have designed a variety of tools which make us mimic something similar. But with the robot, I can sew just like I would sew anything, just throwing stitches as I would normally. And this picture is not that clear, but what's happening here is this hole, there's a hole here, and that's the top of the vagina after the uterus has been removed. And I have to close that hole so there's not an opening inside the vagina into the woman's abdomen. And so I'm stitching this hole closed using suture and a needle, just as I would abdominally, just like open. And the other great thing about the robot is it has a 3D camera. So traditional laparoscopy has a 2D camera. The robot has a 3D camera, and I can see such amazing clarity and depth that I see much better than my naked eyes. It also corrects for any impairment that you have in your vision, as well as much better than I could see with a laparoscope. So the benefits is it helps us to treat more complicated surgeries laparoscopically. The precision dexterity and control, it's more precise around the ureters, the bladder, and sewing up the vaginal cuff. And this way I can do surgeries where the tissue planes are just not as clear. Sometimes endometriosis or cancer, they take the normal tissue planes that divide one tissue from another and destroy them. And this allows me to get into those spaces that have been destroyed with a lot more safety. So this is just example of what the robot looks like. This area here, the tips of these instruments are much smaller than a dime. Okay, and this is how the robot looks, and these are the arms, how they attach in. This is the camera. There's a lens there and a lens there, and the two to come together for binocular vision, where you get to see three-dimensional images. So that's how I would treat Miss Smith, and she had her procedure. She spent 23 hours in the hospital for observation, lost less than 200 cc's of blood, went home the very next morning, and was back to full activity within 2 weeks and was driving by 3 days. She took a total of 1 pain medication after surgery, 1 time. There's something about the energy that we use with this machine that results in such significant pain reduction, even over traditional laparoscopy, where these people have very little pain. I frequently will come in the following morning after their procedure to see how they're doing, and they're sitting up with their makeup on, bag packed, ready to go. Why am I here, doc? I need to go. All right, let's get you out of here. So here's an example. This is something I also see very commonly. I see it every day. This is another 43-year-old with 2 children who has the same complaint. She's bleeding excessively. And she reports that she needs to use a tampon and a pad together, and she has to change it at least 8 times a day during the first 2 days of her flow. She has a little bit of pain, normal pain that she's always had with her flow, but this bleeding pattern has gotten progressively worse with time. So prior to pregnancy, it was probably about 2 to 3 pads per day, no tampon. After delivery, it maybe doubled. And then by the time she got into her 40s, the bleeding got very excessive. She's had a tubal ligation in the past, so she doesn't need any birth control, and she's really resistant to try any form of hormones because she's been told from a friend that she'll get fat if she takes birth control pills. And she really doesn't want to gain any weight. So take a look at her, and her exam, her cervix is normal, and she has a normal uterus. It's not enlarged, it's 7 to 8 week size. It's completely normal on exam. She has a very mild anemia, so her hemoglobin is 11. And an ultrasound reveals a normal shape of her uterus, and the lining is normal. So a little bit different than Miss Jones, because Mrs. Smith, Mrs. Jones has no anatomical problem. She has a complaint that doesn't match her exam. So we diagnose this patient with just excessive menstruation, and we call it menorrhagia, and she's distressed by it. She thinks that this is excessive. She's not happy with the amount of sanitary products she requires. She's fearful of having accidents. She doesn't like to go out on those first few days of her cycle, and she's embarrassed by it. And so we talk about treatment options. Normally, things that we would use would be things like birth control pills, which would result in reduced menstrual flow, but she doesn't want to do that. We also offer her a medicated IUD. There's an intrauterine device that's used for birth control, but it's also used to treat heavy bleeding. And it has a hormone in it. Even though we reassure that it's not going to cause any weight gain, she's very reluctant to do that. So we plan another minimally invasive procedure that's done hysteroscopically called endometrial ablation. So what is that? Endometrial ablation it's a minimally invasive way of decreasing the amount of blood a woman secretes every month from her menstrual flow by destroying the lining. So remember, our menstrual lining is what creates the blood that we lose every month. And the lining those glands in the lining can make a little blood, or they can make a lot of blood. And this procedure destroys that lining to reduce the amount of flow a woman makes every month. And there's many ways of doing this procedure. There's been, for 20 years, there's been this technique and that technique, hot water to burn it, microwave technology, ice formation, and then this new one that is, well, there's been several of these new ones which require electrocautery. So you hear about people having a wound cauterized. You know, in surgery we cauterize bleeding. Well, this is a way of cauterizing the whole lining in one step. And it's an extremely well tolerated procedure. We do it at the outpatient surgery center. There's no incisions on the abdomen or vagina. And it is a way of burning the lining globally in one visit. And we normally takes about 1.5 minutes of cauterization to get at a complete cauterization of the lining of the uterus. The whole procedure, from the time the patient enters the surgery suite to the time she leaves, is about 8 minutes. The results are usually excellent. About 50% of women have no menstrual bleeding anymore. None. So you go take a patient who's bleeding to the point where she's limiting her activities and she has no more bleeding afterwards, she thinks you're a god. She is happy lady, very, very happy. But that's not we shouldn't expect women to have no bleeding, but they should have a significant reduction in flow. They should be satisfied with the results, and about 85% of women are satisfied. And it's quick and easy, and they can go back to their normal activities the same day. They might have a little cramping, a little bit of nausea. Some doctors do this right in their own office without even going to the surgery center. So they just have a pre-medication with a light sedation, like a Valium, a little bit of local anesthesia, and they're done. Most of us do it in the surgery center just because of equipment issues. And it's nice to give the patient the option of having a more, a twilight type of anesthesia. So that's an extremely popular procedure. Unfortunately, not many people know about this surgery. The ones who know about it preach it from, the top of the hilltops from their friends, but we just haven't gotten the word out to the general public that women don't have to suffer. And what's the criteria for a woman getting this surgery? She doesn't need to be anemic. She just can't be postmenopausal, and she has to be bothered by the amount of menstruation. And they shouldn't be planning on having babies in the future because it's not recommended if they haven't completed their childbearing. So that's it. That's a lot of people. So on my last vignette that I wanted to go over is something that's also very common. When you use Miss Sharman, we've got this group of 43-year-olds who've had 2 babies, and this is like a big age where people start having problems. And she comes to the office because she's leaking urine, and she leaks urine when she doesn't want to be leaking urine. We only should leak urine when we're sitting on the pot and ready to go. If we are not in that situation, we call it involuntary leakage of urine. And we can lose urine for all kinds of reasons. But this patient's complaining about it only if she's coughing, like if she has a cold, she sneezes, like when she has allergies, or if somebody tickles her and makes her laugh. So those 3 things. Sometimes when she's jumping up and down, but mainly under situations of stress on the body. So there's some kind of mechanical stress for the body, and such as coughing, sneezing, laughing, and that results in the urine leaking when she doesn't want it and she can't control it. So she has to wear a pad every day. It's not always full, but she just feels more comfortable if she wears a pad, and she's really embarrassed that there might be an odor from the pad, and she just doesn't like it. She feels irritated that she's always had some moisture on her bottom, and it's leading to some pelvic irritation. Sometimes it causes her to be itchy, red, chafed. She doesn't have the symptoms of sudden urge that she can't control. It's not like if she's washing the dishes, she feels an urge to go, or if she puts the keys into the car or into the front door of the house that she feels like she has to go and she can't control it. She doesn't have any of those problems. Those we call urge incontinence, which is another reason why women leak urine. And she doesn't have any pain with urination, doesn't feel like she has a bladder infection. She's just embarrassed by this problem. She feels too young to be having this problem and she wants some help. So do her checkup and reveal that the external genitalia looks completely normal and she doesn't have any prolapse in her vagina. So I don't see any signs that the uterus or the bladder or the rectum, the walls are loosening and things are falling down. But I do see that the tube where the urine comes out, the urethra, it moves a lot. So I put a little Q-tip in there and I look at the line the end of the Q-tip makes, and then I have her cough. And I find out that her urethra moves a lot when she coughs. So the support structures underneath the urethra are lost. And she does empty her bladder all the way. I tell her to urinate, check if there's anything left. No, she's not having an overflow situation. And her urine culture is negative. She doesn't have an infection. So her diagnosis is pretty simple. It's genuine stress incontinence, and that's related to the pelvic floor lack of support of the urethra, the tissue underneath the urethra. Remember, the urethra is a tube that carries urine from the bladder to the outside of the body. And that tissue is broken down through age, genetics, and most often wear and tear of childbirth has resulted in that area to become what we call hypermobile. It moves when it shouldn't move. When we laugh, cough, and sneeze, that area should stay supported. But hers moves, and when it moves, the force of the bladder allows urine to come out, and we don't want that to happen. So if this is an example of her bladder where my hand is, my palm is, and this is the urethra, so when she coughs, sneezes, and laughs, it goes like this. So the urine can just spill out. So what we plan to do is something called a suburethral sling, where we just gently support that tissue so when she coughs and sneezes, that tissue is still supported and that she doesn't lose urine. What did we used to do? Well, even just 5 years ago, we would do something called a Birch procedure. And a Birch procedure is where we make the big incision in the abdomen and lift that tissue around the urethra through the abdomen and attach it to her bones in her pelvis. So the woman would have an incision about this big, and there was a good chance she'd leave the hospital after 2 days, still wearing a catheter for a couple of days, up to a week, because for the healing to happen. But now we plan these little suburethral slings. And there are many on the market, and the one for this patient would be the most minimally invasive option. It's called the Mini Arc. And it's less than 8 centimeters of polypropylene mesh. So it's smaller than your average Band-Aid. It's 1 centimeter by 6 centimeters. And it's just we make a 1 centimeter incision in the urethra, just below the tissue of the urethra in the vagina, and attach it to a portion of her pelvis called the obturator. This procedure takes a skilled person about 6 minutes to perform. It can be performed in a doctor's office or in a surgery center. Within 6 minutes, this procedure is completely done. Patients in the recovery room or walking out the door. The probability of her requiring a catheter is almost 0. And the success rate is no different than the success rate that we had with our previous surgeries, the abdominal surgeries. So this has become the gold standard for people who have stress incontinence. This one I would reserve for people who have a condition like Miss Sharma's. She's not always wet, but she's fearful of being wet, so she wears a pad, but she's not soaking pads. And she doesn't leak urine with just standing up. It has to require some force. So she has fairly mild stress incontinence, but it's concerning to her and she wants a surgical correction. And this procedure can be done very quickly, safely, and effectively. It's not designed for people who've had other incontinence procedures in the past, but there's other minimally invasive procedures that would be helpful for this woman. But this is the wave of the future. So we've basically gone from anywhere from 10 to 15 centimeter incisions to 1 to 2 centimeter incisions to alleviate these common problems. So in conclusion, minimally invasive surgery is preferred. And just to let you know, the vast majority of my patients have minimally invasive surgeries. About 90% of my hysterectomies are performed minimally invasively. And that has just revolutionized how my job is performed. I did my first minimally invasive hysterectomy, besides vaginal, but using the laparoscope, probably 5 or 6 years ago. And going from the first one to 90% of my hysterectomies being performed that way, that trend's just going to continue to improve. I haven't done a Birch procedure, that abdominal approach for incontinence, in probably 4 years. And this is just in a very little snapshot of modern medicine, how quickly things have changed, and I just imagine things changing more and more towards this. We have other fields of specialty that are doing minimally invasive procedures. You might have heard about minimally invasive joint replacement, smaller incisions, quicker recovery, shorter lengths of stay, improved function for people. So basically, traditional abdominal surgery with a scalpel is becoming the exception and not the rule. If we could only deliver the babies through the laparoscope, then it would be great, but still have to make an incision for that. That's pretty much the only thing we make abdominal incisions for, is cesarean section. So that's all I wanted to go over today, to introduce to you these new techniques, and I'm here to answer any questions you have about gynecology in general. And I also have brochures on all 3 of these procedures: the laparoscopic hysterectomy, or the robotic hysterectomy, the endometrial ablation procedure, and the suburethral sling procedure. There's brochures that the companies provide on educating patients, and they're available in the back of the room with Kelly, my office manager.